I'm Dr. Manuj Wadhwa. I'm from Chandigarh, India. I'm the president-elect for Indian Arthroplasty Association, and arthroplasty of knee and hip is my basic practice. It's a pleasure to be here at PCO 2026 to be speaking on how to be building a professional brand in arthroplasty.
It's a big honor for me because my role is today to interview you. So my first question is, because I heard you do a lot of robotic surgeries. So how do you manage robotic surgery in such a high volume setting?
A wonderful question per se, because building a high volume practice is mainly building a standardized protocols. So we not only do robotics, we split it into amalgamated, say certain people get augmented reality. Maybe PCO from France is one of the parameters, people get robotic, and others go in for conventional stuff also. Not 100% of them do robotics, but once you build up a process, the duration of that using technology starts decreasing because SOPs are built up.
But is it still time consuming in your setting?
So now it takes around 8 to 10 minutes extra if you have to use the technology to assist for your surgeries, but mainly the entire homework and the planning happens back of the house.
And what is, in your opinion, the main advantage, the main medical advantage of robotics?
That's still a very controversial topic in the hands of a high volume surgeon. But today I would say, the consumer, which is the patient, many times demands for technology. In real life scenario, we keep talking about precision, accuracy, but that apostrophe comma that 1 out of 5 patients who are unhappy would be finished once we use this technology, I think that would be an overstatement. The results are there. Today you have a number parked to it, I would say that way, that there is a scalability, there is a precision, and there is a recurrence of that precise endpoints that is going to be there, and that's what technology gives you an endpoint. And equally at the same time, the overlay of images, superimposition makes you more confident during surgery that where you want to position your components, they have gone in.
Next question would be about fast-track surgery or enhanced recovery concepts. So, does it play a role in your setting?
A big way. Like I run a high-volume practice, so I call it as a FIFO, fast in, fast out, which is like a fast-track surgery amendment of ERA's models. So where everything is pre-controlled. So we build up protocols, SOPs, from the pre-op to the intra-op to the post-op, everything is laid down. What cocktails they would be getting in, what sort of pre-op medication, what is the fast-track anesthesia, what is the pain control parameters. So for having a highly efficient models, I think this fast-track or ERAS models is a baseline that has to be there.
What about day surgery?
We do it day surgery, but I rather launched it for India. But to be honest, more than 90% of our surgeries are bilateral knee replacements.
Bilateral?
Oh, yeah, bilateral. That in India, the practice is different. People come in a very
91%.
More than 90% of our knees are single-sitting bilaterals, and there we do not have a data. For a very fit patient, educated patient who lives in the main parts of the city, in a unilateral knee, we do the ambulatory surgeries. That means 24-hour stay surgeries.
Yes, in Germany we have many well-educated patients. They are educated by the internet, Dr. Google. Do you have that also in India?
And that's there everywhere.
And how do we manage them?
The social media and the chat GPT and the Gemini-driven patients who come back to you, they have read about the implants, they have read about the technology, and they already have a notion fixed up. So it's like a question bank on a phone that opens up. We don't mind a patient being aware, but to be fancied by those thoughts is a controversy, but it does exist on. So today you have to deal with them. You can't really bypass them. And we try to sit with them, educate them that do not go in for a Google doctor. Pick up your points, pick up the controversies, and we'll give you a consensus and a balanced statement. But ultimately, whatever it is, your empathy or concern has to be coming from the surgeon, and you need to be linked to that. And trust is going to be the biggest exercise in this.
And shared decision making, is that also your principle in managing patient management?
I think the pre-operative counseling and shared decision making is very important. Still, back home in India, the word trust the scalability that follows a very big way, and we are very, very concerned that that connect does not go on. Anything the pre-op counseling to, I would say, post-op also, if something goes wrong, we hold an accountability, we hold a responsibility, and we go on and discuss with the patient and the family on all details that went through. Because every day is not a very sunny day. Sometimes things do not go right, but then also you need to have the sync of the patient going along with it.
And finally, maybe, what, in your opinion, was the most important development in joint arthroplasty over the last 20 years?
Oh, wonderful. I think technology coming in, especially this CT-based preoperative planning, the 3D printing to get across to us in tougher scenarios in, say, complex hips is now really aiding us through. Especially because a lot of Western-made implants were really not a best fit for our patients. Now with 3D printed stuff, CT-based parameters, we can have something which is very, very customized to the defects, to fill in the